a pop-up on your screen. Just go ahead and click OK when you get a chance. Welcome everyone to our second call in this year's series, What's the Latest? Where we're going to be talking about emergency medical systems initiated buprenorphine programs. We have some representatives from Port Angeles and South County here to talk about the programs they have in place. But first, we're going to do a short introduction and then hand it over to the panel. My name is Maureen Oscadal. I'm a registered nurse, and I work with the Addictions, Drug and Alcohol Institute on the state opioid response team. So this call is being recorded, so just a little bit of Zoom housekeeping here. Please have yourselves on mute when you're not speaking, but please feel free to come off mute, particularly during the question and answer and the panel discussion. Feel free to participate either by raising your hand or putting questions in the chat. And again, audio and video controls are in the left-hand corner. So I'd like to begin by acknowledging as we gather today, we are on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our indigenous neighbors. So this is our agenda for the next hour. I'm gonna briefly introduce who's here in the room. They will have the opportunity to introduce themselves more formally once we get into the panel discussion. Then Dr. Chris Buresh is here to provide a overview. He's also going to help with the facilitated discussion that we're having. Then we'll move into the panel discussion. We'll have some time for audience question and answer, and then we'll wrap up and share some of the upcoming trainings that ADAI and the state opioid response team has available. So we're fortunate today to have, like I said, Dr. Chris Buresh from the University of Washington. He also works with Harborview Medical Center and Children's Hospital as an emergency medicine doctor. He will be here facilitating with me today. Again, my name is Maureen Oscadal. I'm a registered nurse with the team. And for our panel, we have Heather Whitmore, an EMT, and Brian Gerdes, a paramedic from the City of Port Angeles Fire Department, and Captain Keith Sharp and Captain Nicole Picknell from the South County Fire in Snohomish County. So before we get into that panel discussion, I'm going to hand it over to Dr. Buresh to provide an overview of why we're doing EMS-initiated BU.
Thanks, Maureen, and thanks everybody for being here. I think this is such an exciting and important discussion. As you all are doubtlessly aware, overdoses, especially opioid overdoses, have gotten to be increasingly prevalent over the last 4 or 5 years, really reaching sort of epidemic proportions. Fortunately, over the last year or so, we've seen that start to sort of decline, although it's still well above sort of baseline levels of 2015 or so. And I would say, if we go to the next slide, I'm not sure this decline is permanent. At least in King County, we get pretty frequently updated records, and we're starting to see a bit of a rebound and things heading in the wrong direction again. And I don't know if you guys feel that where you work, but I certainly feel that where I work. We can go to the next slide. And so just looking at the number of, so the state has an amazing database that you can take a look at EMS calls. And these are the calls from different counties for the number of suspected overdoses just as recent as April. And we can go to the next slide there. And then you can see that of people who get called for an overdose or of overdose calls, a big number of like 20 to 40% of those, so 1 to 2/5, don't get transported to the hospital. And if it's transport, we can go to the next slide. And so that's a real problem. This is some King County data that just shows the incidence of sort of repeat overdose and death after a call. And you can see really that first couple of months, the incidence of repeat overdose is incredibly high. If we go to the next slide, then you can see, and you don't spend too much time looking at this, but you can see the survival curves really dropping off for all ages, but especially early on after that overdose. We can go to the next slide here. And so this is such a, I think, an important topic because these are real opportunities to intervene and make positive change in somebody's life when they're in a really difficult spot. I think the need is incredible. The population that you see when you are working in the pre-hospital space is incredibly high risk for repeat overdose and death. And getting people started through the EMS system is maybe the lowest barrier way into treatment that I can think of. And so, all of these things just sort of come together nicely. EMS is right in the middle of it, enabling us to really take care of some very sick people who have a lot of needs in a way that meets them right where they're at. And so, so thank you for being here. I'm really excited to hear what all of our experts have to say.
Thank you, Chris. Thank you very much for that introduction. I think that really sets the stage well for the panel discussion that we're about to have. Just to reintroduce everyone, we have Heather and Brian from the City of Port Angeles Fire, and from South County Fire in Snohomish County, we have Captain Sharp and Captain Picknell. And so I'm gonna stop sharing my screen and so we can see everyone more clearly, and invite each of our panelists to introduce themselves more formally, to share where they're coming from, the work they're doing, anything they want to share about their buprenorphine, their EMS-initiated buprenorphine program, why you feel it's important, and then we have some prepared questions to pose to you all. So I'm going to start with Captain Sharp, if you want to go ahead and kick things off.
Sure. My name is Keith Sharp. I'm a captain with South Snohomish County Fire and Rescue. I work in the Community Resource Paramedic Office, and I specifically oversee our MOUD program. We call it the CORE program. We started our CRP program about 12, 13 years ago, and it's grown from there. So our current team exists of one 24/7 community resource paramedic, so able to respond to acute crisis calls 24 hours a day. And then we have community health workers who work 10-hour days, and they do coordinated follow-up care. We, about a year ago, were lucky enough to receive a grant that allowed us to start up our MOUD program through the University of Washington and CROA. And so that's where we got started. That allowed us to have my position to oversee this program, plus a community health worker specifically for follow-up for SUD calls. So what's it look like? That's our history, our staffing model, and how our team kind of works is when we have an overdose call come in through the 911 system, our crews respond to the call. While en route, they request our 24/7 community resource paramedic show up, who brings with him the ability to give out Narcan leave behind kits and administer buprenorphine in the field. And so that's the big one for us, is being able to administer that buprenorphine right then and there. When we show up, our crews often revive them with Narcan, which puts them in precipitated withdrawals. Historically, our patients have wanted to just leave the scene to alleviate their withdrawal symptoms, go wherever they got to go to get rid of that. Now we have that tool of buprenorphine that allows us to alleviate those symptoms right then and there, also creating a better headspace so now that we can get them have into that conversation about what are the next steps. Do we want to go to the emergency room? Do we want to go straight to detox? Can we give you buprenorphine today and then get you into treatment tomorrow? All of those things are now tools in our toolbox that we just didn't have before. And so I think why this is important to us is the reality is we weren't able to help for the past 10 years. As the crisis grew, we were trying to do the same thing over and over again, which was revive them, offer them a ride to the hospital, they leave, and then lather, rinse, and repeat, and we do it all over again. Now we have a way to facilitate change, and we are seeing really good results in South County Fire. our latest numbers are of the people that we're able to finally make contact with in our program, over 70% remain in treatment or off of substances to date. And so that's amazing considering it used to be less than 10%. So I think that's where we're at in South County Fire.
Yeah, I agree with whoever put, there's a message in the chat that's incredible, and I completely agree. And someone else asked, I think this is more of a rhetorical question, but did you say 70%?
Yeah, I think we're at 72% right now.
Thank you. Yeah, that's wonderful. Thanks for sharing that. Those are really awesome outcomes, and speak to the tool. The buprenorphine is a great tool. It also hints at the work you're doing and the way you're doing it is also very effective. The people who are doing that work, and gaining rapport pretty quickly in an emergent situation. Next, I mean, I'd love to hear from Captain Picknell. You're also on you work together. Tell us more about your role.
Okay, and I'll just add a little bit, to what Keith said. So I came into the office on an assignment about 5 years ago. It was a 1-year assignment. And our community resource paramedics initially are just to work on decreasing 911 use from people that are high utilizers or familiar faces. Started out with 1-2 CRPs, and then I came in, and we have just continued to expand. And this buprenorphine program is one area that we were able to find funding to fund it. And it was a pilot. I will say this, it was a pilot. We followed North County Fire with the pilot, and then we watched the pilot go from here to several other agencies in the state, thankfully to UW and CROA. It's been so successful that I do know a Department of Health that oversees our paramedics and EMTs has adopted it. As of last month, they announced they're adopting it as something that we will carry. So I think that just goes to show this pilot was an idea. They're seeing such great success. And here's what I just want to add to Keith's comment. The difference, this is what would have happened with people if we didn't have the buprenorphine. They would either say, no, I don't want anything to do with you, and they leave. And then they just want to go get more fentanyl or whatever their choice is because they don't feel well, because they were either trying to detox themselves or they were given Narcan. We've seen both cases. So they don't feel well, so they want to fix that feeling. So we will probably see them overdose and see them again and potentially die. Or we've seen them go in, sit on our aid car bed in the hallway while we're waiting for a bed, and literally texting their dealers to get something to fix the problem. They'll be in the hospital for a short amount of time. They don't like how they feel and they just want to leave. So with this option, I think the blessing is that we can provide them with something to feel better, have a better conversation. And this team can actually go straight from the streets or their home and take them straight into a detox or a recovery center. We don't have to use the ER as that route, and we can offer them something, and that we believe is more successful because we're meeting them where they're at, and then we're taking them straight to the need that they have versus routing them through a whole nother system with lots of questions and papers to sign and another provider that has to see them. We recently asked one of our ER docs, and I know it's getting better, if I bring them in, how long until you can give them a medication to feel better? And he said it could be up to 3 hours. So there's no way that they would have ever had a fighting chance. So that's what I think the benefit of having it right there in the streets, in their home. That's what I think the benefit of this team is. And I will say this too, our crews, the firefighter, EMTs, and paramedics are like, thankfully, I now have something I can feel good about and give them something to feel better instead of saying, okay, you don't want me, you don't want the ER, see you later. they now also feel like they have something that helps them feel successful in their work and that they have a solution for them. So those are the things I will add to the program. So thank you.
Thank you. The way you're describing it is almost like it's like a win-win for both the teams that are responding and for the folks that you're helping in the field. So that's, you know, sometimes we think mostly about how we're serving the patients, but we also have to think about, like, you know, how effective do we feel as providers? And this is, again, a tool to sort of enhance that. Thank you. Brian, tell us about your program and where you're coming from and what it looks like where you're at.
So my name is Brian Gerdes. I'm one of the community paramedics with Port Angeles Fire Department. And I don't think I'm going to go into great detail about the program. I think Keith Sharp and Captain Picknell have both. I think we have similar programs and similar approach to this. So one of the things I can add is we are in a really good spot to offer certain services based on the needs of the community because of the way our programs work at our fire departments. You know, this is back in 23. I knew we saw it coming for a long time, but in 2023, we had, I think, 51 fatal overdoses. That put us at number 2. Clallam County was number 2 in the state for the amount of fatal overdoses by population. I can corroborate Captain Sharp's numbers there. We're at roughly the same amount. We're seeing about a 70% success rate with that. And over the last year and a half, we've seen a sharp decline, and we brought those numbers down low enough to where we're now number 13 in the state for fatal overdoses. So it's pretty, we didn't know that, but that was going to happen. But I think that our hypothesis was that while we've had a wonderful reception sort of to Narcan and us making Narcan available in the state of Washington, actually across the country, I think what we were seeing is that these people were no longer engaging. We were essentially, it's a weird picture, but I'm going to say it like this. We're essentially throwing Narcan in the streets. They're coming out of the forest, picking up the Narcan and going back into the forest. We're reducing engagement. They need the Narcan. I'm not saying that's not important, but they also need to engage with their mental or their behavioral health and their physical health providers, and just be reminded constantly that there are people to help out there. We feel like if we engage with them in that moment of crisis, that is maybe the only place that we can break the cycle. It's not going to happen in the emergency department an hour later. It's not going to happen when we're doing outreach and we're trying to get them off the streets. Another thing that these programs do is they help crew morale. So we have kind of a closed loop communication system. Crew will go on a 911 call for an overdose, transport the patient or not. We'll get somebody to engage with the patient and we'll advocate until that happens. But in the end, we come back to the crews and say, remember that overdose you went on Tuesday? Well, now that patient is in treatment, 30 days later, they're in court, trying to get custody of their child back and things are in line. So it's there's a lot of parts to this, but they really are to be given this opportunity. It's pretty cool.
Yeah, that's great. And it sounds like you are able to you have some way of tracking or evaluating where clients or patients end up. How far out in terms of tracking, how many months are you able to?
We've chosen to just continually track it. We're building a kind of a data dashboard where we track the overdoses, multiple overdoses over time, so you can see, months, days, like when they next overdosed. We're trying to develop that a little bit further, so we can also add in, like maybe when they went in and got out of jail, or maybe when they went into treatment and got out of treatment, and trace that over that path, spread over those months and years, so you can see if maybe there's some correlation, and maybe we need to be engaging with them at different points during this time.
Thanks, Brian. I think I appreciate that from a data perspective. I also appreciate it because it humanizes the individuals that you're seeing. You're seeing a holistic picture of someone's life versus the in the moment response. So I think that I imagine that also impacts how people view the individuals that you're responding to in the long run as well. Heather, our last person to be introduced, please introduce yourself and share whatever you feel is helpful or important that we should know about the work you're doing.
Yeah, so I've been with Port Angeles Fire Department for about 6 months now. I'm a community EMT.
Heather, there's
just
a little
about to
bit
be
of
a
a
community
echo.
medic. I was hired on with the intention of us creating 2 separate post-overdose response vehicles. Right now, one of the things that we're really working on is capturing us being available to respond to these calls. Right now, we're just a Monday through Friday, 9 p.m. to 5 p.m. Brian's really our data guy. So we're able to capture when these overdoses are occurring. So when we can trying to capture all of these. We've found that Tuesdays at 2 p.m. is one of the biggest times for overdose responses, but a lot of these overdoses are occurring after our work hours. So creating 2 separate units, we're just working on trying to figure out how best we can capture being able to respond to these and being available for those.
Thank you. I'm going to hand it over to Chris to ask the next question and sort of delegate how you want to get those
I think
answers.
there've been some fantastic questions coming up in the chat, and there's honestly so many questions that I want to ask beyond what we've already prepared you for. But I think one of the things that came up in the chat that I think is really important is to talk about how you decide to initiate buprenorphine. Would you use a COWS score and what the cutoff is? Are there 2 different COWS scores depending on the situation that you use? And then what dose of buprenorphine you start out with, and how you decide how to dial that in. I'd love to hear from people who have been doing this, how you do that.
Sure, I could go. So we do use the COWS score. So if we go up and if we initiate with Narcan and put them into precipitated withdrawal, then our COWS score is 5 or above. So if we come on scene and we've precipitated that withdrawal and their COWS score is above 5, then we will initiate with 16 milligrams of buprenorphine if they fit the criteria, right? They can't have used methadone within, I think, the last 72 hours. They have to be of a certain age and able to consent. It's really low barrier, but we start off with 16 milligrams. We'll reassess their COWS score after 15 minutes. If they're still above a 5, we can administer an additional 8 milligrams. Excuse me. And then we'll reassess after 15 minutes. And if they're still above 5, we can call medical control for an additional 8 milligrams of buprenorphine administered. So that's up to 32 milligrams. Now, if it's not precipitated with Narcan, then we're looking at above an 8. So if somebody is trying to white knuckle it and quit fentanyl on their own or opioids on their own, and they start going into withdrawal, we can show up and actually administer buprenorphine at that point. But instead of a 5, we do a COWS score of 8, and it's at the same milligrams.
Yeah, thank you. I think that's really cool. You have 2 different thresholds depending on the clinical situation, right? Then where we give them the Narcan, we can go ahead and start this versus they're trying to be abstinent and really struggling. So I think that makes tons of sense. I think that's a really great idea. You'd mentioned that using methadone in the last 72 hours is an exclusion criteria. And I do think that's really important to just sort of call out, because people who are on long-acting narcotics like methadone, that can be a really tough transition from methadone to buprenorphine, and you can really prolong their precipitated withdrawal if they've been using methadone recently. And so thanks for bringing that up. Are there other excluded criteria or things that need to be that make you decide that maybe buprenorphine isn't the right way to go?
No, not really as far as exclusionary zones or exclusion criteria, but what we're finding out there is that a lot of people have had a bad history with buprenorphine, and that prevents them from trusting us. And I think a lot of that has to do with not initiating at a high enough level in the past, and it threw them into withdrawal symptoms. And so we just got to convince them that at the levels we're giving it's usually pretty effective.
Yeah, that's got to take some real coaching though, because I know those experiences really stick with people.
I will say also looking at the chat, yeah, if they're pregnant or underage, we're not going to initiate. At the very best, we'll contact medical control, but really that's transport criteria for us, and we'll just let the hospitals make that decision.
Yeah, and I will say that it is very safe in pregnancy, and withdrawal is bad for pregnancy, but that is a tricky thing that may not be best managed in the field. So going to hospital is a good idea. What about from Port Angeles? Do you all have the same criteria or different criteria?
It's similar criteria. We have a max of 24 milligrams. It's changed, so maybe I'll talk about that. We are paramedics are pretty big on evidence-based medicine and what works in the field and what doesn't. So all we had to draw off of beginning this whole journey was advice from clinic-based MOUD programs. So we spoke to experts there who said, well, this is what we do in the clinic. And then we've had to adjust it because people who are stable enough to walk into a clinic and go through their MOUD program are not who we're working with. So giving somebody 4 milligrams of Suboxone and then reevaluating every 30 minutes, they'll likely be throwing up or punching you in the face. So so we had to quickly adjust that. Pregnancy, we're kind of in the same thing. Physicians, I think they're pretty smart to consider we only have, 5 to 10 minute transport times usually. So let's just get them down to the hospital. Methadone use, it was initially 10 days. We adjusted that to within 48 hours. And so we start with 16 and then we'll give another 8 for a total of 24. We use the same COWS score range. We started at less than or equal to 8 and we changed that to less than or equal to 5.
That's great. And I think, I think you got to have a good data guide to be able to sort of iterate like you have been, because there hasn't been a lot of guidance for this, right? This is kind of the Wild West. And
there
so
are some good examples.
how things are going is important. Yeah, sorry, go ahead.
Oh, there are some good examples. I mean, we have San Francisco has a pretty robust community paramedic program, and they've been working with probably the worst, the fentanyl crisis in their area is probably worse than it is anywhere else in the world. So making some adjustments based on things they've done. Of course, Seattle has a lot more throughput of overdoses. So hearing some feedback from them and their program has helped us to kind of feel more confident in what we're doing.
Yeah, and I think, there's another important point to highlight is that really, you learning from each other and doing this together is really important because it is a really new thing. So paying attention to the data, tracking how things go, being willing to make adjustments when you need to, and sharing your experience with other people, I think is really key to making this work for everybody. So that's great. I think some of the other questions I've been hearing, and one of the things that we wanted to ask was, how you facilitate follow-up care then. And it sounds like there's a few different strategies that you all use. And so I just open that up to anyone on the panel. What do you do to facilitate follow-up care and ongoing abuse?
I can talk on that. So just the way we do it out here, we're a smaller community with a city population of 20,000, a rural, level 3 trauma center. And we like to be a little bit more active in advocating for them. So during 911 call, we will respond with the crew, with an ambulance crew. And then we just try and find the right opportunity to engage with the patient, try and get rid of all of the unnecessary personnel. So try and tell the police officers to go fight crime, tell the firefighters to go shine their wheels. And then we stay on scene with them, and we will follow them down to the hospital, follow the transporting crew down to the hospital, engage with case managers, with their physician, the nurse, so that we can try and smooth that pipeline out. And we'll stay there. We'll usually call one of our SUD specialists, either peer professionals or SUDP, somebody that can evaluate them. It does help in the hospital setting when the doctor has 20 patients that they're working with, to have somebody come in and evaluate a patient for placement in a detox facility or treatment facility. So it's actually gone pretty well up here, even though not everyone's on board yet, because they still go, you gave them what? And I imagine other places have encountered that, but we find that's the best. Just staying there, talking to them, educating them, letting them know, hey, this is what's going to happen next, helps to keep them in that bed for a little bit longer, because usually these patients will leave against medical advice within 30 minutes. And then and now you're out of that sort of, you responded to this crisis where you revived them. They're upset. They're at that moment, at that point of crisis, that you can connect with them. And if you just leave them alone, then it's the same thing as we've been doing in the past, by just transporting them down to the hospital and leaving them there.
I think I heard some pretty important points there. You know, going to the hospital is still a good option, but getting people involved, like SUD navigators or peers, was like a pretty important part. And then just really staying with them through the process and trying to help keep them calm and realize that they're getting help, I think, and giving them some, someone to talk to and be with, I think probably makes the whole world of difference to people that are otherwise scared and not feeling too good. That's great. What, besides going to the hospital, what other solutions have people found? I saw Scale Northwest pop up in the chat. I'd be interested to hear how people have used that, or if there's other. I think I heard Keith and Nicole talk about taking people to treatment centers directly, even sometimes.
Yeah, so we actually try to divert from the hospital whenever possible, only because we have the facilities and we have the infrastructure here to support that. If we initiate with buprenorphine and drive them to the hospital, now they're sitting at the bottom of the list for triage, and they're going to sit there for quite a while because they don't really have any big complaints. And we find that whether they're on bup or not, they just generally AMA from the hospital. So we want to make it a better experience for them. So whenever possible, whether we initiate with bup or not, we try to get them into something other than the ER, unless they're not, medically stable. So we will get them into detox. We have good communication with our detox centers around here, to where we can call 24 hours a day, 7 days a week, and get them usually placement into one of our treatment centers, detox centers, if that's what they're going for. If not, we also have good communication with our other treatment facilities for like outpatients. So we may initiate with buprenorphine, get them stabilized, set them up with outpatient treatment the next day, and then get them a ride to that treatment. So we have a couple of nonprofits in our area that help support with transport. We have something called Courage to Change. And then we have our firefighter foundation, where our firefighters put money into this foundation, and that helps us pay for Uber Health transports to our detox facilities. So if we show up at 2 a.m, somebody overdosed, we give them buprenorphine, make them feel better. Now the next steps is we get them a transport to one of the detox facilities where they can stay there for 5 days. And then we'll follow up. Our community health worker then follows up after the fact and makes sure that they get into treatment for maybe a 28-day period or whatever supports them best, outpatient treatment, and they really do the heavy lifting after the fact.
That's fantastic. I mean, I think this is one of those things that's going to vary sort of community by community, right? Depending on what sorts of resources you have and what sorts of support structures are available. I will say that I've worked in one of the ERs where those people show up, after getting bupe and they have to wait on the gurney for sometimes hours, and I hate it. And we're trying to change that, but it's hard with all the incoming traffic, and we totally recognize that we are not, serving that patient population well. So I think there was a question about leaving behind buprenorphine, and I think that's probably not. Just want to be clear. I think that's kind of against the rules.
We don't leave behind
right?
buprenorphine, but we do have a partnership. Well, there's the Seattle buprenorphine number, the King County buprenorphine number, that we can now get them a bridge script where we can get them to a pharmacy and get them a bridge script to see them through. Maybe it's the weekend or whatever. We also have a partnership with another clinic called Conquer Health that'll write them a bridge script 24 hours a day, and we can get that to them the next morning to see them through until they can get their treatment or outpatient treatment.
Chris, it also looks like Brian in Port Angeles, they have some ability to get bridge scripts as well from attending physicians. Brian.
Yeah, that's great. Do you want to talk a little bit about that, Brian?
Well, since when we started this program, we hadn't really, or when we added this sort of post-overdose response, it didn't have, we weren't in communication, let's say that, with the hospital. We realized that we needed to make a change, and we changed. And it also takes some time for the hospitals to kind of get in line. In larger cities, you may have a hospital. There may be 6 hospitals. One of them is usually the one that might say take the overdose survivors. So, we'll take them to Harborview or something. Everyone will take to Harborview. And I've seen that in other larger cities too. I'm not sure exactly how Seattle does that, but going in and speaking with the physician that's in charge of that patient and just saying, hey, like Captain Sharp said, we need to get them through the weekend so that we can get them down to an MOUD program. We've already spoken with the physician. They're on board. Can you get them through the weekend, Monday at 10 a.m.? They'll start on microdosing until we can get them to some treatment option, like intensive outpatient or inpatient treatment. Leaving them with bupe, that's I think we feel the same way about that. That's not really an option at this point. We have been called by some of our partner agencies to say, hey, I have a patient that doesn't want to engage with law enforcement or fire, EMS. They don't want to go to the hospital. Is there some way we can get them through? And then that's just kind of a case-by-case basis. And they're sort of, unfortunately at this point, they're sort of edge cases. So I'm sure we'll explore that further if we have more throughput.
That's great. I think I saw somebody put something about Scala Northwest in the chat as well. Has anybody used that to connect people to care in their post-overdose setting? That's another resource that I think could be useful. Brian, were you going to say something about that?
We're trying to initiate a conversation with them. I think we've heard from each other in another meeting, and we didn't know anything about them. So they reached out to us and just said we should talk. And so I think we're going to start talking about that and see how that works, us being so rural.
Yeah, we have a relationship with Scala Northwest. It's great. If we can't, we do have partnerships with our local agencies, but if we can't find a bed or a place to go right then and there, then Scala Northwest is another one of those tools that we use that allows us access or knowledge into what our options are out there. It's a great resource.
I want to maybe just ask one more question, and then we'll just kind of throw it open to, and then we can maybe start going through the chat or take other questions. But if you had to give some advice to people that were going to start something like this up in their community, What are some of the big take home points, or some of the important things to do well or to watch out for?
So, take the leap. It is a really easy program or it is very cost beneficial. It is, you already have it available, or you don't already have it available. You already have all you need. Seattle is already adding EMTs piloting, giving it. So if you have an ALS unit, that's another option. Other things that you can do is just.
Well, I think what Heather's trying to say is that there's different ways you can go into this. So if you don't have the personnel and you can't fund, because a lot of our programs started or are still running on grant funding. And we struggle all the time with trying to figure out how to increase our numbers or even just keep the program going. So, you can still start this by piloting it in your ambulances. You don't need to hire new crews to do it. The reason we did it is because it's new and we wanted to make sure that we had some practice before we kind of built it into our system. So I think that what would be best is that eventually we move into putting it in every ambulance and making sure that every patient at every hour of the day is reached. So either that is us hiring a couple more community paramedics and putting us on the 24-hour shifts. Well, we just changed 48-hour shifts, but putting them on the shift so that you have 24-hour response from that. Right now, we work bankers hours. We don't work on weekends. And like Heather said earlier, we can't connect with everyone. We have seen that while, Captain Sharp mentioned the 70% success rate, and our numbers are the same there. We tracking that data, we do know that if we don't engage with these patients and we leave it up to the street medic crews that are normally going out there doing it, it is a dramatic difference. Ours is saying that it's 3% success rate if we just do things the way we've been doing them. So you can do this with very little investment, or you can take the time to build a community paramedic program. Medical program directors like to know that they have someone that's specific to that. So buprenorphine's new. I know when we spoke to our medical program director and said, "Hey boss, can we do this thing?" He was like, what are you talking about? I'm scared. And so we had to make him feel like it wasn't a scary thing. And then after we showed him that we're not just running around injecting everyone with buprenorphine, he became a lot more comfortable with the idea of maybe down the line putting it in every ambulance and letting other people be involved in that. Does that answer your question?
Yeah, I think that's great. I think that also answers some of the other questions I've seen in the chat about, what are some of the hurdles you're seeing, or how are you sort of overcoming resistance on the part of your colleagues to doing this. I think that's a nice segue into that. And what about others on the panel? Yeah.
If I could add a little comment to that, Doc. You get to get crew buy-in. When we first started this, there's a little bit of bias. These aren't people that treat our crews very well. They didn't have a lot of answers. They knew that if someone Narcaned them, there was this belief they're just going to go get and find their substance again, and they don't treat us nicely. It's this cyclical cycle of go into the ER, get back out, go into the ER. We see this person every other day. They didn't see how this was going to help. And so originally Keith and I were allowed to bring it just to the CRPs, just to we have a 24/7 team. I do think that's important, but we could only bring it to this one provider. And then our crews weren't really clued into why it was important. It didn't really kick off until we trained every single paramedic in our monthly training. And Brian's right. Our direct medical director, we have a county direct medical director and then a department medical director. He also was like, it's not really in the ERs. I'm not really comfortable with it. So every step of the way we had to educate someone. And it didn't really kick off till we educated also every single paramedic and they understood what this could do for the human that needs the help, and also what could it do to help them have a solution, because it's hard. We want to put out fires, we want to save people, and if we don't think that there's anything we can do, we start to lose faith. It's actually called compassion fatigue, and our people were really fatigued with this specific topic. So once they gave them a solution, they were like, oh wow, we're all on board because we're seeing results. And then Brian and Heather are right. The crews need to have the follow-up that this person is still in recovery. This person has now lived this many months in care so that they know their efforts are being successful. And if there's one other area that I think when you start a program, I wish we were automatically dispatched. We have to wait for a crew to ask for us. And we can see 4 overdoses happen in one of our sections of area. We can see 4 different overdoses come in. The reason we don't get dispatched is one might come in as a cardiac arrest, one might come in as just a slumper, one might come in as a person passed out, and then the fourth one might be an overdose. So those 4 things have to have someone go on scene to find out, oh, these are all overdoses. And so currently we don't really have a great system that automatically dispatches us. So we do have to rely on others recognizing this might be a buprenorphine moment. That's probably a gap for the system right now.
Yeah, I mean, I think that's all part of learning, how to do this and figuring out just kind of better ways of doing it. And I think, Nicole, what you said about, my feeling is that this probably does mitigate a lot of burnout and compassion fatigue. And I think, as Brian was talking about collecting this sort of data about people's sort of life force, and Maureen was mentioning how it's really important to humanize people. And I think it is true. We got to recognize that we see people kind of on the worst time of their lives, the worst day of their lives sometimes, and they may not treat us that well. But boy, I tell you, run into some of these folks after they get on the medication, and it you don't have to have 1 or 2 of those encounters when they're going to court to pick up their kids, or they're going to work for the first time in a long time to really turn your perspective around.
Hey, Dr. Buresh, I'd like to also say, I'll put my email and address in the chat. We've designed the program. If anybody's interested in the program, we're happy to give it all out for free. Like, this is for the public. Like, it should be everywhere. I want it to be everywhere. So I'm happy to give out everything we've created in this office and use what you want or don't use what you want. But if you're looking to put something together, don't do all the work. Let somebody who's already done the work do it for you.
Yeah, there's no need to reinvent the wheel. I agree. There's a question in the chat about, and maybe this will be, we're starting to run a little short on time, but some people, when they call for an overdose, will say, oh, it's just somebody who's not breathing well or some respiratory stress. They've been coached to say that it's not an overdose. And what are people's thoughts on that? And how do you think that affects the response? And are there ways that you sort of try and compensate for that? Or I think, Nicole, you were just talking about trying to figure out which calls are the ones that you should go to and which ones aren't. What would your suggestion be to figure out how to dispatch those more effectively?
That's a great question. I'm glad you asked. I have no answer. I just know this. We can't have our CRP specifically dispatched to overdose calls because they come in from anything from a BLS-1 to a MedX, which is a CPR in progress. So until we figure that out, I don't know how to figure that out.
I'm really curious why. Oh, sorry, Brian. Why would you coach someone into not saying it's an overdose or I don't understand that, because in my eyes, if I see it, I have a TV and I go, that's an overdose, I can send my team member. So I don't know why you would coach a person into not saying what it really is, because that actually convolutes all of our data as well. It's a difficulty breathing. Well, that could be asthma or overdose. Like, I don't know. Then all of our data becomes really odd because it becomes subjective as to what did that really end up being. I think that's an odd thing, unless there's stigma behind it, is probably why.
I think that's a lot of it. I certainly have my own thoughts, but I'm sorry, I'm probably not saying your name right. If you want to, I saw you raise your hand.
Yeah. This is Lee. I asked the question. I work with a series of different groups, and it comes up to coach people to not mention overdose, even when it's like highly suspected, just because of the stigma or worry that, police will come and treat folks fairly poorly, or they're worried there'll be a slower response if overdose is mentioned. And so that's why in some of these trainings it's coached to say that, and then some of them's not. And as someone who coordinates different trainers, I'm like, okay, like what should folks be saying, just to make sure people get the best care.
Yeah, I think that really speaks to the experience of stigma, and people have called 911 before, and the response is delayed because law enforcement wants to clear the scene first or something. I've heard lots of those stories as well. Brian, I see your hand is up. I think you just muted yourself when you took your hand down.
I did. Thank you. We've only been using Zoom for 4 years. Give me time. So I think the way we've done this so far is we have 2 units. We just use the CP11, CP12 for unit designation. They've both been added to the run cards for a suspected overdose. So we do get toned out to overdoses if that's what we think they are. The crews are aware, on the other hand, and like what Captain Picknell was saying, is some of us that have been doing this for a while, you can kind of, when the tones go out and you read the CAD information, you can sort of gather that this could be related to an overdose. Girlfriend on scene states something, and you're like, you know what, that could be an overdose. Let's just send a community medic down there, even if we haven't been. And a lot of those, you're right, they will be a CPR call or something else. And sometimes in the CAD message just says CPR in progress. You don't know what's going on. So when a crew arrives, they can always say, hey, can you dispatch a CP unit to our location? And then that way somebody's always connecting with them.
It's great. I love the proactive approach, and I'm sure that when you hear where the call is coming from, some of those details, it probably sometimes gives you the spidey sense starts tingling. Well, I wish we had more time to talk about this. I want to hand it back over to Maureen for to kind of wrap it all up, put a bow on it, and talk about some of the future trainings. But before I do that, I just wanted to again thank our panelists for the incredible work that you're doing, really, really bending the curve for some really vulnerable people and giving them a chance to really turn their lives, major impacts from their lives. And thanks to everybody for being here to hear about these incredible programs.
Yeah, thank you. Thank you, Chris. Thank you, Captain Sharp. Thank you, Captain Picknell and Heather and Brian. This was a real, I agree with Chris. I wish this was a 90-minute session and not 60. We had a lot to talk about, and there was a lot of good information sort of flowing in the chat. So I saved the chat, and we'll try to add that to the follow-up email so that people who may not have been paying attention there will see some of the responses that our panelists were sharing back and forth. Thank you all for being so active. And thank you for the work you're doing in the community. It's really wonderful to hear that this initiative, this intervention is being expanded across the state, and that you all are having such a good experience with it. I work on the primary care side, so I see the long-term outcomes for folks, and it's just nice to hear that people that you're seeing are having positive experiences with getting started on buprenorphine and a really traumatic time in their lives. So I appreciate your compassion and your initiative and your willingness to be here today. I'm going to go ahead and share my screen and go over some upcoming trainings that we have available for folks. Just so that people are aware of what's going on in the coming month or so. We're currently in the middle of a series called Stimulant Health Matters, where We have people with expertise around health conditions that can be affected by methamphetamine use. Folks sharing their expertise around these issues. So on Monday, we had Kayla Cross, a nurse practitioner, talk about neuropsychiatry and mental health related to methamphetamine use. And on this coming Monday, we have two nurses from Spokane's CHAS program, CHAS Health, talking about wound care and skin health concerns. And then in 2 weeks, we have Dr. Hidano from Harborview Medical Center, who will be talking about cardiovascular concerns. We also have a day-long symposium on the topic of methamphetamine. It will be a combination of panel discussions with people with lived experience, healthcare providers, peers, and others who provide support to people who are patients who also have methamphetamine, who also use methamphetamine. And there will also be some data shared and some conversations with people with lived experience around what the actual experience on the ground is related to the data that we're seeing. And these are some ongoing upcoming trainings. I facilitate a nurse care manager call. Actually, it's happening later this month. We have someone from King County Public Health who will be talking about stigma in opioid use disorder care. Dr. Chris Buresh runs the emergency department series, and the next call for that is in July. And Dr. Duncan and I facilitate a quarterly call caring for patients with opioid use disorder in the era of fentanyl. That next call is in August, and we'll be talking about methadone and sort of the changes in access and updates around methadone for opioid use disorder treatment. And then we have our monthly calls, the monthly jail call facilitated by Dr. Mandy Owens, monthly care navigator call facilitated by Leilani Don, and a monthly adolescent OUD call facilitated by Dr. Alexis Ball and Dr. Addie Adwell. And then just some resources from ADAI. We will be sharing these slides as well as a recording of today's panel discussion. So that will go out in the next couple of days. Please feel free to reach out if you have any questions. You can email the adai@uw.edu, and your questions will get forwarded to the correct people. Thank you again, everyone, for joining us today. Really appreciate your time and expertise. We'll see you in a few months for our next What's the Latest?